Welcome to a really important and interesting webinar today presented by one of our great friends of Parkinson Foundation, Western Pennsylvania. Psychosocial aspects of Parkinson's and potential interventions. We are joined by Dr. Bradley McDaniels. He is an assistant professor and program coordinator for the Rehabilitation Studies program at the University of North Texas. He earned his PhD from the University of Kentucky, followed by a postdoctoral research fellowship at Virginia Commonwealth University School of Medicine. His postdoctoral work has been dedicated or was dedicated exclusively to Parkinson's disease, which lays the foundation for his ongoing research. Dr. McDaniels explores critical non-motor aspects of Parkinson's disease, and he will be discussing those today. Thank you, Dr. McDaniels, and please take it away.
Thank you for the introduction, Casey. I'm always excited to be back with your group of engaging folks. So I was telling you before, this is a fun part of my job, being able to present these things and some of the work that the team that I'm involved with has been doing. So without further ado, we will jump right in. I'm not going to spend a lot of time going over basics of Parkinson's. I think those of you who are on this call pretty much know what Parkinson's is, where it comes from, how many people have it, all of that good stuff. So we're going to jump right into looking at these things in Parkinson's disease that truly affect quality of life, right? I think that, we know Parkinson's is a disease of motor dysfunction, but I think the literature has become really clear, showing that it's not the motor stuff that causes the quality of life issues. It's a lot of these non-motor features, right? And some of the work that we've done over the last couple of years has begun to highlight some of these things. This was a study that we did a couple of years ago, and we looked at what are these things that decrease quality of life. And 4 of the things that were commonly seen in the literature were demoralization, apathy, stigma, and loneliness. And I'm going to spend some time as we move along talking about each of these 4 things. But maybe more importantly, I'm going to spend some time talking about what do we do, right? I think we do a lot of research in the medical world where we identify problems, but oftentimes we don't say, what do we do about the problem? And so we're going to spend some time towards the end talking about what are some potential solutions to these issues. So we think about stigma, and stigma is pretty common for people with Parkinson's disease. This is another paper we did a couple of years ago. More than 50% of people with Parkinson's report that they try to conceal their disease, right? You hold your hand so you don't see the tremor. You maybe don't go out in public because you don't want people to see your gait that's abnormal or potential fall. And among those people, 50% report that they've actually experienced stigma in society. And, again, we see the stigma is always more associated with the visible symptoms, the tremor, the dyskinesia, urinary dysfunction. But there's also stigma associated with mental health, right? It's a real issue in our society. And having depression, anxiety, apathy, these things are stigmatizing. So oftentimes we don't talk about those issues that we have in our lives. And stigma is typically higher in people who have younger onset Parkinson's than those with the older onset, for a variety of reasons, right? Society doesn't typically associate Parkinson's disease with young age, right? If you ask someone, what do they know about Parkinson's? They'll say older people get it. And so there are always questions when we see someone who's young, who has PD. But then we've got this issue of double stigma that can occur for marginalized populations. Somebody who's older and has Parkinson's disease, now you may have double stigma against you. Someone who's a woman, has Parkinson's disease and older. Now there may be 3 things. Someone who's a minority and older and female and Parkinson's, right? So you can see how these things begin to build on one another and can be quite problematic in our functioning and our desire to engage with the community. So what are the impacts of stigma? right? It makes sense that there's social withdrawal, isolation, and loneliness, right? If one is afraid that going out in public, I'm going to be judged, I'm going to be looked down upon, I'm going to be discriminated against, I may choose not to engage in those things in my life, right? Which also stems from the anxiety that you may feel. You may not engage in help-seeking behaviors. You may not go and see your movement disorder doctor because, let's face it, there are reports of movement disorder doctors who have stigmatizing beliefs about people with Parkinson's disease. So if you feel like you're being stigmatized by your movement disorder specialist, you may not go and follow up and get the treatment that you need. Shame, depression, demoralization, all of these other psychiatric and neuropsychiatric challenges are all associated with stigma and tend to create an additional burden to Parkinson's disease in general. So the last one on that list a second ago was demoralization. And demoralization is a new construct in the field of Parkinson's disease. Some colleagues, Dr. Greg Pontone and Indu Subramanian, whom I've been working with for a long time, we ran across this. We were having a discussion a couple of years ago and looking at depression and anxiety and apathy, all of these neuropsychiatric things that are common in PD. And Dr. Pontone said, you know, Brad, there's this thing of demoralization that's found in the cancer literature that is very common, but nobody talks about it in Parkinson's disease. And I think we need to look at it. So we did. And we've spent the last, year and a half working on this paper that is just about ready to be accepted in a medical journal shortly. And what is demoralization? It's a persistent inability to cope with a pressing problem, right? It's very similar to depression. It can look like depression, but there are some specific differences. And those differences are, the symptoms are helplessness. I feel like I can't do anything to change the current situation that I'm in. It's hopeless. There's nothing that can be done. Maybe the life as I know it is over. You may have that belief. I no longer have meaning in my life. Maybe your meaning was being a caregiver to someone. Now you can't do that anymore. Maybe your meaning was being the primary breadwinner for your family, being a parent. Those things can potentially change, right, with a diagnosis of Parkinson's disease. And the real verbiage that goes along with demoralization is this idea of subjective incompetence. And that's really a pejorative phrase, right? But what it means is I don't have the ability to cope with the things that I'm dealing with in my life. And that's really the thing that sets demoralization apart from depression. And so demoralization, subjective incompetence, depression really is characterized by this idea of anhedonia. And what that means is the inability to experience pleasure in life. So that's really how we can distinguish the two. However, they occur very commonly in conjunction with one another. So it wouldn't be abnormal to see somebody who's got some demoralization and depression at the same time. And again, why would one become demoralized? You know, again, I talked a little bit about these changes in social roles in our lives that take away our satisfaction and confidence. Intolerance of uncertainty is another area that we're writing about as we speak. This idea of when I don't know what to expect from the trajectory of my disease, it becomes really challenging. And that's one of the hallmarks of Parkinson's, right? Someone comes in, they're diagnosed, they ask their provider, what can I expect from this disease moving forward? And they really can't give you an answer other than it's going to progress, right? Because it looks different for everyone. And psychological inflexibility, what that is, it's a fancy way of saying I'm not able to adapt to challenges in my life. And when I'm not able to adapt, employ coping strategies, change my perspective on things, it ends up causing distress in my life, depression, demoralization, things like that. And then, of course, appraising a situation as hopeless. And I talked about there's been very little work on this in Parkinson's disease. So stay tuned. Once this is published, I'll send it to Casey and she can share it with you all. Apathy. This is a quick one. Oh, Didn't mean to hit that. I think you all are familiar with neuropsychiatric feature of apathy, right? It's very common in Parkinson's disease. It's quite problematic because there's no treatment for it. Most of the providers don't really know what to do with it. Dopamine works, levodopa. Sometimes cholinesterase inhibitors work. SSRIs or SNRIs for depression sometimes can be effective for treating apathy, but there's not anything that's has proven effectiveness regularly. And it's challenging because, again, it overlaps with depression, dementia, demoralization, and being able to tease out what is actually going on with someone can be tough. And the range of prevalence for apathy is roughly 40%, but it's as high as 70% in the literature. So it's a very common syndrome that people experience, particularly with neurologic conditions. It's not just Parkinson's disease, multiple sclerosis and other neuro conditions are also very common. So apathy is one of those things, right? That feeling of, I just don't have the motivation to engage. I know my doctor tells me I need to exercise. I know my doctor tells me I need to be in social settings, involved with groups. I just can't. I don't have the motivation or the goal-directed behavior to do that. Doesn't mean you don't want to do it, right? It's actually a syndrome in us that impedes our ability to engage with life. All right. Here's another interesting topic, loneliness, right? So I think we knew that loneliness, I know that the medical community knew that loneliness was a challenge. But I think throughout COVID, we really saw the detrimental effects of loneliness, right? And loneliness is different from social isolation. Social isolation is what we experienced during COVID, where government said, you need to stay home in your house and not get involved with people in the public, right? So it was a quantity relationship. I'm by myself in my home with no social interaction. Now, loneliness can stem from social isolation, but just because one is alone at home doesn't necessarily mean they feel lonely. That makes sense. So really, it's the discrepancy between the desired relationships that I want and the actual relationships that I want. Do I have people in my life whom I feel connected with? And it doesn't matter whether it's 1 or 20, right? Is there this connection? And so we saw this, everything that was negative skyrocketed during COVID: depression, anxiety, apathy, demoralization, suicidal ideation, divorce. All of these things got worse as a result of, with a contributing factor of loneliness. So what does loneliness really cause, right? 64% of people are more likely to develop dementia who report loneliness, 2 times more likely to develop Alzheimer's, increased depression, anxiety, cognitive decline, and 29% increase in coronary heart disease and 32% increase in coronary stroke, right? Real issues that are the result of simply being lonely and not engaged. This was put out by the Surgeon General a couple of years ago. And it's a pretty fascinating statistic, looking at the effect of lacking social connection as it compares to smoking 15 cigarettes a day, drinking 6 alcoholic drinks a day, physical inactivity, obesity, and air pollution. So out of all of those things, social isolation has the biggest effect on mortality, which was stunning to me to actually see the data, that it's more detrimental than smoking 15 cigarettes a day. So I say that, and you'll see throughout some of these slides, there's a constant reminder of the importance of connecting, having a social circle, having social support, right? Being involved with others in the community. So here's what you're thinking, right? Thanks for all that great news. We know these things that are associated with Parkinson's disease, and none of those things that I just shared with you are good things, right? But the good news is there are things that we can do to offset some of these challenges. And so that's what the rest of this presentation today is going to focus on, because I think that it's always better to talk about solutions rather than problems. So there's an area that I began doing research on actually when I was a PhD student years ago. And it's this idea of positive psychological capital. And it actually stems from the business world. A guy named Fred Luthans, who is at the University of Nebraska in the School of Business, began looking at what are characteristics of people that make them better employees. And they were looking at all kinds of variables: education, work background, all of these things. But what they ended up coming up with was these 4 characteristics. And across the board, these 4 things: hope, efficacy, resilience, and optimism. He referred to it as the hero within, right? The acronym HERO. Those are the things that determine who's going to be a good employee at work. And so they began back in early 2000s looking at this research, and there's been a lot of stuff published on it. And so then we began thinking about what about these things in health conditions, right? How do these characteristics of positive psychological capital impact health outcomes for people with chronic illness? And there was very little work on it. This was back in 2016, 17, 18 when I started working on this. And I really couldn't find anything. There were maybe 3 or 4 studies that were published at the time that talked about this, and nothing really compelling in the literature. And so I began thinking, all right, I'm going to do some work on this. So we did. And we started looking at the role that these things play in, like, people who have Parkinson's disease, and whether or not they participate in activities in life, right? Social settings, exercise classes, just other engagements. And there is a correlation between these 4 things and positive outcomes for people with Parkinson's disease. So how did he come up with this idea, right? He began looking at what are the types of capital that we are aware of right now. And excuse me, he talked about economic capital. What do you have? Your finances, the money that you have access to, the assets that you have. Those things are important in positive outcomes in our lives. So is human capital. The things that I have accomplished, my education, the knowledge that I have, my work experience, those things also can affect outcomes. What about social capital, right? Who do you know? I would bet that many people who are on this webinar today have gotten jobs in their lives because of somebody they knew, have had things happen for your benefit because of somebody that you knew. So it matters too. But then his real interest was in this, again, positive psychological capital, and that's who you are. What are these core characteristics about us as individuals? And he also wanted to make sure that these things were changeable, right? Because if you say that someone needs to have, let's see, what would be a good example? Someone needs to be 6'5" to have positive outcomes in their life. I can't change that, right? So basically, if someone is 6 foot tall, you go, sorry, but you're not going to probably have positive outcomes in your life. So that was the theory behind Luthans and coming up with these 4 characteristics. Was we needed to be able to show that they were malleable to intervention, that we could do something to improve them, which would in turn improve outcomes. So that's kind of a background for psychological capital. So let's talk about each one of these things. So hope is our belief that we can change the future or reach a desired goal. The key in that definition is we can change, right? Hope, that's really the distinguishing feature between hope and optimism. We'll talk about optimism in a minute. Optimism is really focusing on this belief that things will work out and be okay. Hope says, I have this goal in my future, and I believe that I have the ability to affect change in that goal or help me be able to reach that desired goal. And so with hope, you have the will, which is the intent to reach this goal, and you have the tools, which are the pathway that allow you to reach those goals. And so here's a depiction of those three characteristics. Hope always has to be associated with a goal for it to be considered hope. So whatever that goal is that you have, do you have the intent or the desire to reach that goal? So that's you've obviously got to have the desire. And then do you have the things around you that will allow you to achieve whatever that goal is? So my goal is to be able to walk 2 miles. Okay. My intent would be that is something that I want to do. I believe that through effort, I can reach that. And the means would be maybe there's you're going to go for a walk every day. You have a treadmill in your house and you're going to engage in that. You're going to have a group of people whom you meet at the gym 2-3 days a week, and you're going to have a walking club, right? So you've got to have all three of these things for hope to be affected as an outcome. So does it really matter, right? It's the operative question that we keep talking about, the so what. So yeah, here are the health benefits of hope that are published in the literature. Fewer chronic health conditions, lower risk of cancer, fewer sleep problems, higher psychological well-being, less depression, less anxiety, less psychological distress, better immune system, decreased sensations of pain, better social well-being, right? So there's the piece that we say, so what? I know it's great to have hope, but does it really matter? This is what published literature says from studies, that there are absolute benefits to having hope. So that's the first one. Self-efficacy is number 2. And it's the belief in my ability to produce desired outcomes from my actions. And it's not what you believe you will do, it's what you believe you can do. So it's you maybe someone tells you that rock steady boxing is a great option for an exercise class for people with Parkinson's. Someone with low self-efficacy would say, I'm incapable of doing that. I can't do it. And what we would need to do is figure out how can we improve that person's self-efficacy to have them begin to believe that they can engage in that activity. And so and we're going to talk about that in just a second. What does that look like, making that happen? But it's getting to a place where I believe I can try, and then let's see what the outcome is. And self-efficacy is often domain specific. I might feel really good about my efficacy at my job. I might know that there are all these things I do at work. I'm great at them and I'm very comfortable doing them. But I might not feel that good about my ability to engage in exercise classes and do things like we're seeing in this picture here, some type of Parkinson's disease exercise class. So Henry Ford's quote, I think, is appropriate here. Whether you think you can or you think you can't, you're right. So our mindset is largely determining what the outcomes that we're going to experience are going to be, right? So how do we find self-efficacy? Again, the operative question. And there are several ways from the literature. Albert Bandura was the psychologist who really began talking about self-efficacy many moons ago. And he said there are these 5 ways that we can improve self-efficacy. And the first one is mastery experiences. I've had positive experiences in the past. So you think I can't do something, but maybe you think back in your life about a time that you thought you couldn't do something else, but you worked at it, you tried it, you did it, and you go, I was able to do that before. I can apply that same thinking to the situation I'm in now. Vicarious experiences. I've seen others like me, i.e., with Parkinson's disease, experience success in this activity, rock steady boxing, right? So you're seeing someone else who is similar to you, who's able to do it. And you go, well, maybe if they can do it, so can I, right? Another key issue of us being connected socially and in our groups of people who are like us. Verbal persuasion is another way to improve self-efficacy. The important piece in this, people, is whom I value, right? Have told me I can do this activity. Someone can tell me I can do something. If I don't value their opinion, I don't take that to heart. But if someone whom I value, someone who's in my social circle, somebody who is my medical provider, my physical therapist, my counselor, right? Someone whom I've invested some time with encourages me that I can do something, I'm much more apt to believe that I can do it. So it's finding people like that in your life. Number 4 is physical and emotional states that we experience. So if I experience positive physical and emotional states when I'm engaged in this activity, I'm much more likely to believe I can do it and I want to engage in that activity. If I don't experience those things, then I'm probably not going to want to engage. And the last thing is imagined experiences. It's simply just imagining yourself completing this task, whatever it is. Imagining yourself beginning rock steady boxing. Imagine yourself walking around the neighborhood. Imagine yourself having lunch with a friend 2 days a week, right? Whatever that may be that you feel like you can't do, these are ways that we can begin to feel like we can accomplish more of those goals. So again, we're going to talk about the benefits. So what? Why do we even care about self-efficacy, Brad? Well, people who have high self-efficacy have lower procrastination and avoidance. They actually engage with things with life. They have less stress and depression. They utilize healthcare less, right? Why would that be? Well, because maybe I feel like that there are things that I can engage in that are going to improve my health. So I don't necessarily need to go see someone to make those decisions for me. They have better health-related quality of life, better PD self-management, increased resilience to stress, improved ability to problem solve, increased ability to deal with unexpected obstacles. That's that psychological flexibility and that intolerance of uncertainty that I talked about. You're able to deal with those challenges. Decrease psychological distress because you have adaptive coping skills, right? You realize that there are these coping strategies that are available to you, and I believe that I can do them and they'll be effective. Maybe it's meditation, maybe it's mindfulness, maybe it's art therapy, whatever it may be. I believe I can engage in that. Ability to maintain and achieve goals, better quality social relationships. So again, I mentioned earlier about the social piece, right? You're going to see that common theme in every one of these slides. That it underlies everything that we do with Parkinson's disease. And it's a reminder of how essential it is for us to connect socially with other people. What about resilience? I think resilience is probably one of the ones that you guys may be more familiar with than some of these others. But it's the capacity for positive adaptation in the face of adversity that threatens your functioning. What does that mean? That's a great definition. The second definition on this page is better. It's the ability to bounce back, right? A tree that's in the wind is in a storm is blowing and it's blowing toward the side, 75-mile-an-hour winds, and the winds stop and the tree stands right back up. That's resilience. That tree was being adversely affected by a storm, and now the storm has stopped and the tree stands back up. It's the ability to bounce back. Skill to overcome setbacks with greater confidence. And it's interesting, along the lines of resilience, there's this idea called post-traumatic growth. It's another area of interest that we have in our research group. Looking at post-traumatic growth says, well, let me back up. Resilience says that after something happens, some adversity in your life, you can bounce back to where you were before that adversity happened, right? That's resilience. Post-traumatic growth takes it a step further. Post-traumatic growth says, not only do I bounce back after the adversity stops, I'm better after I bounce back. So I'm better than I was before the adversity even started, right? It sounds counterintuitive, but the way that our bodies adapt and the way that we learn new strategies in dealing with stress in our lives can teach us skills that make us better than we were before. And it's not an uncommon theme that we see across chronic illness, people with disabilities, people who have encountered tragedies in their lives. Oftentimes you see them and their attitudes are so positive, and you're thinking to yourself, how can you be that positive given what you've been through? And that's the idea of post-traumatic growth. Something has changed in us that's allowed us to become better, stronger, more resilient than we ever were before that event. Again, does it really matter if I have resilience? So here's what the literature says: lower rates of depression and anxiety, lower cardiovascular disease, stronger immune function, lower psychological distress, better psychological well-being, greater quality of life, and of course, greater interpersonal connections. So 3 out of the 4 we've done. Got one last one to talk about. Optimism. Optimism is a little bit of a tougher one because depending on the literature you look at, sometimes people view optimism as a character trait. Things that are traits are oftentimes difficult to change. And the way that Lutherans looked at this, and through the literature we've seen, they look at optimism as a state-like outcome. And states and traits are different. Traits are part of ingrained in who you are. States are things that we experience, and because of a given situation, I am optimistic. Doesn't mean that I'm always an optimist. So a state would be I'm optimistic in this scenario. But Lutherans believes that we can change optimism, in fact, make it better. The argument becomes on the other side of that coin. If you have someone who is a pessimist by nature, can you change them to an optimist? And there is literature on both sides of that question. So it's a little more challenging than the other 3 that we've talked about. But optimism in general is the belief that good things will occur in my life. Optimists typically can view hardships as learning opportunities and temporary setbacks. And a pessimist, here's a quote from Winston Churchill: a pessimist sees the difficulty in every opportunity, and an optimist sees the opportunity in every difficulty. Now, I like this last one even better, but George Bernard Shaw: both optimists and pessimists contribute to society. The optimist invents the airplane, the pessimist the parachute, right? So it's all about our perspective and the way that we look at things that happen in our lives. It's not Pollyanna, meaning you just go through life thinking everything's grand, everything's perfect, I don't have any problems. No, it's facing the things that happen. I've received this diagnosis of Parkinson's disease, and it stinks, and I'm not happy about it. But life still goes on. There are still things that I'm going to be able to do. I might even be able to learn to do some new things that I never was able to do, excuse me, before. And so it's just shifting our perspective a little bit, looking at things we encounter. So here are some differences between optimists and pessimists. The optimist seeks information about problems, and they plan and they actively cope with how they're going to deal with it. The pessimist tends to distract yourself from the problem, avoid the stressors, and deny that a problem even exists, right? So an example of that would be someone who's diagnosed with Parkinson's disease and they don't want to go for follow-up care. It'll be okay. It's not that bad. I'll be all right. I'm going to be able to manage this on my own. Optimist seeks benefits in adversity. They positively reframe stressful situations, and maybe they use humor to deal with some of the challenges. The pessimist tends to focus on the distress and what's been lost. Again, I have Parkinson's disease. My life is over. I'm never going to be able to enjoy things in life the way that I used to enjoy them. I'm going to not have my social network that I used to have, right? All of these things that are not uncommon thoughts, particularly upon diagnosis of a chronic illness. An optimist tends to accept the reality of the situation. I have Parkinson's disease, but there are still options. The pessimist tends to give up trying to cope. Why bother? Life's over. Optimists focus on solutions. Pessimists focus on problems. Here's the other piece that's been on every slide. The optimist has more social connection than the pessimist. Being around optimism is contagious, right? People who are optimistic make us feel good about things in life, that there is a positive side to this situation. So, end of the day, what are the things that we can do, right? We've talked about hope, optimism, resilience, self-efficacy, and we've talked about the challenges that we face with PD. So one of the things that you can do that is an achievable goal is to set achievable goals and pursue them. Small goals in your life. I'm going to exercise 3 days this week. And do your best to exercise 3 days this week. That will improve your self-efficacy. That will improve your hope. That will improve your resilience. Also improve your optimism. Find new ways to achieve your goals. Maybe you want to exercise, but you don't like rock steady boxing. So maybe you do yoga, chair yoga. Maybe you walk on a treadmill. Maybe you have a few friends that you get together a few days a week with, and you go on walks together. Another great technique coming from the cognitive behavioral therapy world is practicing cognitive reframing. Is there any other way I can look at this problem in my life? Right, because maybe I looked at this issue that I'm having and I can only see it as a negative. Can I find any positives in it to look at? And sometimes it's really difficult. Again, I told you it's not Pollyanna. We just don't say everything's great in life and move on. It takes effort for us to begin to think, is there anything that I can take positive from this situation? Engage in positive self-talk. I can do this, right? It's instead of I can't, it's maybe I haven't yet, right? Those are two very different words that, we can ask someone when they say, I can't do that. You can't or you won't. Even that's a different discussion, right? So begin to think about how can I reframe the way that I talk to myself, that I am able, I am capable, I can do this, I want to change, I want to feel better, I want to engage with people in my community, right? And of course, increase social connections. It's an essential component to having positive outcomes in just about everything in our lives. And gratitude. Gratitude is one of the simplest things that we can engage in that will have positive health outcomes in our lives. So it's a worldview toward noticing and appreciating the positive things in life. It can be considered a life orientation. Just the way that I go through my life, am I grateful for the things that I have? Am I grateful for the things that the people whom I've encountered? Am I grateful for some of the challenges that I've encountered, that I've been able to work through and potentially overcome? Or maybe I'm still in the middle of that challenge, but I'm learning something about me along the way. Am I grateful for that? Robert Emmons is the foremost researcher on gratitude. I think he's at UC, he's retired now, UC Fresno, maybe in California. He's called gratitude the most transformative force in the cosmos. That gratitude can transform someone's life from negative to positive very quickly. And so it's how can I begin in my life to think about the things that I'm grateful for? And we're going to talk specifically about that in a second. It's considered an essential lubricant to social interaction. Again, people who are grateful are much more encouraging to be around than people who aren't. When you're grateful, you're going to draw people to you, and people are going to see something in you that's attractive to them. Gratitude correlates highly with autonomy, environmental mastery, personal growth, purpose in life, and self-acceptance, all things that are important to positive outcomes for us. So thinking about gratitude and how can I have more gratitude for things in my life? Oh, that's the next slide. So this is, again, the same slide I've showed you all the way along. Does it really matter if I have gratitude? This is what the literature says. People who are grateful have better subjective well-being, means that when you ask them about how they're doing, they tell you they're doing well. They have lower stress. They have improved sleep. They have less fatigue, right? Which is clearly an issue with Parkinson's disease, one of the major non-motor features that people have, or people report. Decreased depression and anxiety, more happiness and life satisfaction. They adhere better to their medications, their exercise, and their diet. They have more hope and optimism and resilience, right? So by improving gratitude, we can improve the positive psychological capital features that we talked about earlier. Hope, optimism, resilience. Self-efficacy doesn't necessarily correlate so much with gratitude, but we can improve those things simply by having more gratitude in our lives. So that's the operative point, right? What is it that I can do to have more gratitude? And it's just a grateful reappraisal. How can I look at situations in my life and find areas that I can be grateful for, right? You can take, I would argue, you can take any person and you can say, take all of the things that you have to be upset, distressed, bothered by in your life and make a list. And then I can say, on another sheet of paper, make a list of all the things in your life that you have to be grateful for. I can promise you to a person, the list on the right of things to be grateful for will always outweigh the other list. In someone's mind, they're probably thinking, well, that's not really the case. An example is all of the things that we have in our lives that we take for granted, that I take for granted, that I need to be grateful for, right? I can see. I've got 5 fingers on each hand, 5 toes on each foot. I can walk, I can talk, I can hear. I can love. I can engage with others. I have a home. I have air conditioning. I have a bed. I have food, right? And that list goes on and on and on. The things that I forget to be grateful for on a daily basis. I think it's important for us to remind ourselves that despite our hardships, there are lots of things that we still have to be grateful for. One of the ways that we look at that and we can learn to do better is to develop a gratitude list. One of the simplest ways to do that is every night before you go to bed, write down 3 things that you're grateful for. Add to that list daily. Don't repeat the same things tomorrow that you repeated today. You do that every day and you watch that list grow, and it will begin to foster gratitude in you because you'll begin to realize, I do have a lot to be grateful for in my life. Then grateful contemplation. Again, just thinking about those things in my life that I have to be grateful for and reminding myself that I have them. Behavioral expressions of gratitude. Tell someone else that you're grateful for them. Write them a note, send them a text, pick up the phone and call them. And don't only say, I'm grateful for you. Tell them why you're grateful for them. I'm grateful for you because you're a great friend to me and you're always supportive of the things that I need, right? I'm grateful for you because anytime I need something in my life, you're always there to help me out. That also begins to foster a heart of gratitude in us so that we can begin to feel more grateful for the things in our lives. And again, our perspective can begin to shift from focusing on the negatives of Parkinson's disease, which, again, let's just be real. There are a lot of challenges with Parkinson's disease. For those of you I've not shared with, my mom has Parkinson's. She's had it for 14 years. And that was the impetus for my going back to school, getting a PhD, doing the research that I do, is to find something to help make her life a little bit better tomorrow than it was today. And so I've seen the things that someone with Parkinson's disease goes through. I talk to her on a daily basis and hear these challenges. But we have these same types of conversations about ways that she can shift her perspective and begin to look at things differently. The other way to foster gratitude is through social connections. And again, that social connections piece has permeated everything I've said today. It is one of the most important things that any of us can do to improve outcomes, to improve our state of mind, to improve our attitudes, to improve our hope, optimism, resilience, self-efficacy, gratitude, is to have social connections. Find people who can support you and love you and help you through your struggles. So I think that is what I have. And I always like this slide when I've got folks that aren't my students, because I share this with some of my students and they're too young to understand who Porky Pig was. But I think most people on this this webinar today will know who Porky Pig was. So got an email there. Casey knows how to find me. I'm always happy if you guys have questions, anything I can help you with. I can share these slides with Casey and she can share them with you. There's nothing proprietary on them. And so that's all I've got for you today. So thank you for your time. Enjoy it.
Thank you, Dr. Bradley McDaniels.
I'm happy to entertain any questions that anyone may have.
There's a few in the chat. I'll start with those. I'll just read the first one. Would you say demoralization occurs with cognitive decline and losing insight with hallucinations and delusions?
I'm not sure exactly the intent of the question, so I'm going to answer it in a couple of different ways. I don't think it's the result of any of those things, right? So I don't think there's necessarily a neurobiological mechanism that causes the demoralization, but I think the demoralization can result from health changes in our lives. I begin to have cognitive decline, therefore I begin to feel like it's hopeless. My mind's never going to get better. There's nothing I can do to improve it. My doctor gave me a prescription for Aricept, and they said it's really not going to do a whole lot to help my cognitive functioning, but it might preserve a little bit of it. And right, so you're having these thoughts and you're going, I don't know what I can do. It's not going to be long. I'm not going to remember my family. And so you could see how those permeating thoughts can begin to lead to a state of demoralization. So I think that's what we've seen in the literature really with demoralization. It's anytime that someone experiences I'll call it a traumatic change in their life. And I've had this debate in some papers that we've published with reviewers who have said Parkinson's disease isn't traumatic. I'm like, I would disagree with that. I believe it is. And I believe there are post-traumatic stress responses to a diagnosis of Parkinson's disease that are real. And so I think that, I think I see Mike is putting something else in the chat. Is it referring to the same question? Yeah, so I meant since non-motor symptoms like cognitive decline causes things like apathy. Yeah, again, so I don't think there's the neurobiology connection between cognitive decline and demoralization. I think it's more of a response to the fact that I'm having these changes in my cognitive abilities, changes in my gait, even that's a motor feature, changes in my social connections, right? Any of these changes that I view as negative can lead me to a place of demoralization where I feel like I'm hopeless, I'm helpless, life as I know it is over, and I don't know how to cope with this challenge. And I think that's what we really see across the board, whether it's PD or cancer or any other type of chronic illness or diagnosis. I hope that helps.
Thank you. Does that help, Mike? This is more of a comment, but a question to a degree. But with a chronic degenerative disease, does adversity ever end?
Ah, that's an interesting question. Um, I would say probably not, right? Because just by definition, it's chronic, which means it's going to continue in perpetuity. And it's progressive, which means that it's going to get worse. So the challenge is, how am I going to approach these potentially unknown things that are going to happen in my life, right? We know that motor symptoms with Parkinson's disease get worse over time, right? Sometimes it might take 20 years, sometimes it might take 2 years. But what we can tell you is over time, it's going to get worse. You're probably going to need more levodopa or Sinemet over time. And you may end up having dyskinesias at some point because you're taking so much levodopa that now all of a sudden I'm having dyskinesias as a result of the levodopa in my system. So I believe the changes and the adversities will always continue. I think what can change is my mindset and my ability with how I'm going to deal with. In other words, how am I going to cope with these challenges in my life? Do I have the things in place, i.e., social relationships, a great support system, a good medical community, maybe a good counselor, good physical therapist, right? Do I have the things in my life that allow me to be able to be more psychologically flexible as I'm dealing with these changes that inevitably are going to happen? So, yeah, I think it's always important to be real and honest as we're talking with someone about Parkinson's, to say it's not going to get better over time. But there are things that you can learn to do that maybe make you appreciate life in a different way than the way you did before. And, one of the examples I've seen across the Parkinson's community, people that I interact with, is how many people have engaged in art, right? I've met more people who never did anything with art. All of a sudden, they got diagnosed with Parkinson's disease. They found a community. They started drawing or doing with clay or whatever it may be, doing something with art, and they found a love and they found a purpose and they found meaning in doing that. And they said, if I had never gotten diagnosed with Parkinson's disease, I never would have experienced this new part of my life that is great. And so I think, again, that's that cognitive shift and the cognitive reframing that we can learn to have is, despite this challenge, let me look at the things that I can still do or some new things that I've never done before.
Thank you for explaining that, Dr. McDaniels. Any other questions? We have a few more minutes. You're welcome to type them in the chat. You can unmute yourself by just ask that you please just ask one question if you unmute yourself. Oh, here. I like that. Like, even though I have Parkinson's, I've met great people I never would have met before.
Yeah, that's a great point, Mike. I think about that regularly. All of the people whom I've met through my journey of working with the Parkinson's community, I've met a lot of great people. Casey and Christine at Parkinson's Foundation, Western Pennsylvania, I met maybe 3 years ago, just because something I think that I published or a talk that I did somewhere else that they found, that got me connected, right? And these things have connected me with so many people, and the same with people who have Parkinson's, who have gotten connected. And it's that vicarious learning that can help with self-efficacy, that you begin to connect with other people who have experienced a similar struggle to you and who are doing well despite that struggle. And we never know if, did I meet someone for them to help me or for me to help them, right? The answer is yes to that question, right? Because it's not always a unidirectional relationship. There are seasons in my life that I'm the helper, And there are other seasons in my life where I'm the one being helped. And so there's such a value in meeting these people who just have different experiences than me, who can share and say, this is my struggle and this is how I navigated that. And I can go, wow, I, I never thought about that as a coping strategy, but maybe it's something that I can employ in my own life and begin to use myself. So yeah, I think, these connections are invaluable to help us all.
Any additional thoughts? Questions? Yvonne had mentioned it's important to share the networks like Parkinson Foundation Western PA to connect with resources, to spread the word.
I have a thought.
Go ahead, Sydney.
Okay, I'd like to thank our presenter. I'm a massage therapist, and what I have found, first of all, I love this series anyway. Okay, so I change my whole schedule around and make sure I can catch this because it's so informative. But what I found particularly interesting today is that as a massage therapist, I find myself doing a lot of counseling when I'm doing table massages and even when I'm doing chair massages. Table massages, people have more time to interact. Chair massages, 10 or 15 minutes, people want to run questions at me. What I have found particularly interesting that the presenter gives us is I look at it from the perspective of the caregiver. The presentation today is something that I certainly would advocate caregivers share and experience. And if they can see these slides or something, it would be tremendously beneficial to them. Um, as I listened to the presenter, I constantly was thinking of the caregivers that I deal with. In my massage business, what I do, I give caregivers complimentary massages when if they're with me when I'm working with the patients, because their mental and social well-being reflects directly onto my client. And my client's well-being is based directly upon how the caregiver feels from day to day, moment to moment, stressful situation to stressful situation. So I thank you. I believe that this is a good presentation for the caregivers. And it was well presented also. Thank you. Thank you
Thank
very
you.
much.
Thank you, Sydney, for making that point. I clearly neglected to say that. So often when I give these talks, I'll say it doesn't matter whether you're a patient or a caregiver, the stuff's the same, right? Quality of life outcomes are affected by all of these things. And I think oftentimes, and I can tell you from the literature, caregivers are largely neglected in the research. And what we know, and you said this very well, Sydney, is you can't pour from an empty cup. So if the caregiver is not doing well, odds are pretty good that the person with Parkinson's disease is also not going to be doing pretty well. So if we don't take care of ourselves, it's the old adage of an airplane, right? You put your own oxygen mask on first before you help someone else. I need to make sure that I'm good, then I can be prepared to take care of you. So thank you, Sydney, for bringing that point up. That was great.
Very well said, Sydney. Okay, there's a comment. Curious, or let me ask you this, Dr. McDaniels. Do you have another few minutes?
Absolutely.
Okay. Well, it won't take too much of your time. Curious about an example of neurologists stigmatizing Parkinson's.
Yeah. So one of the pieces that we saw in the literature when we were writing our stigma paper was when, oftentimes people with Parkinson's disease have difficulty showing emotion in their facial expressions, right? They get what's called masked face. And doctors will often view that as the patient doesn't care. And we could see that routinely in the literature. And so imagine you're seeing your movement disorder specialist and you are gravely interested in the information that he or she is presenting to you, but your facial expressions may not show that. And so they think that you're disinterested. They think that you really don't care. They think that you're not paying attention to them. and they may be dismissive of you. And that was the one that stood out the most that we saw in the literature. I think the other one that sticks out is when a patient has apathy. And again, that can be misconstrued as I don't want to engage in the things that I need to engage in. And so a doctor can stigmatize that as well, saying you're just not interested in really improving your motor functioning. And that's why you're not going to exercise. So you really don't care. That may or may not be true. Apathy is a neuropsychiatric phenomenon that happens people with Parkinson's. And it doesn't mean I don't care. It just means I don't have the motivation to engage in whatever that activity is. So it was interesting when we were writing that paper and we kept running across these things and having conversations with people who have Parkinson's, sharing with us their experiences sitting in the movement disorders doctors' offices, feeling like they were being judged or stigmatized. So it's yeah, I don't know. I can't tell you how common that is, but I know that it has happened, and I think still continues to happen, unfortunately.
Thank you for elaborating on that, Dr. McDaniels. Let's see.
My pleasure.
Another question. Okay. My wife talks about the difference between the mental health challenges presented when she was dealing with stage 2 cancer and the challenges she faces with Parkinson's. She says the issues and anger or related feelings more mirrors her time visiting with stage 4 patients. Does this jive with what you were seeing in your demoralization research?
Well,
but we'll stop there for a moment.
Yeah, says her issues mirrors her time. So I think that what you're talking about is what we see particularly in the cancer research with the idea of demoralization, right? The more progressed the cancer is, the more demoralized the person who has it becomes, right? Because as you're getting more and more toward end of life and needing palliative care, you're likely going to be more hopeless, more helpless. Your meaning in life is going to decrease, and you're not going to know how to cope. So absolutely, I think that the worse prognosis that one has is probably lends to more demoralization. And I think that I don't know that that's true in Parkinson's disease in particular. I think, again, the challenge with Parkinson's disease, one of the differences between Parkinson's disease and cancer is depending on the cancer, depending on when it's diagnosed, and depending on the staging, there are oftentimes treatments that can put someone's cancer into remission, right? We don't have that for Parkinson's disease. So upon diagnosis, for what we know today, there's not going to be improvement in your Parkinson's over time. And I think that's where the demoralizing thought at diagnosis comes from. So is it someone who's had Parkinson's for 25 years and their motor functioning is really poor? Maybe they're having cognitive decline, maybe having some Parkinson's dementia, Lewy body dementia. Are they going to be more demoralized than someone at diagnosis? I don't have the answer to that. I don't think anybody's done that research yet. Wouldn't surprise me if they were, but I think that there's still a significant amount of demoralization that happens right at diagnosis when it's explained properly about what Parkinson's disease is. Hopefully that kind of addresses that a little bit.
Thank you. There's a second part. Chris, if you don't mind, can you unmute yourself and just say the second part?
Yeah.
Thank you.
I think that I 100% ship everything you're saying about the stigma sometimes actually being laid on the patient by the movement disorder specialist. One particular moment was a movement disorder specialist after 2 or 3 years of treatment saying, "Oh no, you may not even have this. We'll send you to go get the PET scan to prove that." And the PET scan was devastating. The movement disorder specialist actually laughed as he was describing the PET scan, and my wife was not happy with that description. But she was frozen by reading the cold paper. I was coming through the phone at how this person was describing the future course of my family's future, and I can't think of how that damaged the trust in a relationship like that. So I
Yeah.
100%, there are moments, and I know everyone doesn't have a great day every single day, but I can't imagine the course of this discussion where that was even remotely thought to be a non-stigmatizing event to the patient. So
Yeah. That's, thanks for sharing that, Chris. And I'm sorry that that was an experience that you guys had to deal through. I'm sure that was challenging. That was, we wrote another paper a couple of years ago about giving the diagnosis of Parkinson's disease. And we talk about those issues, about how important it is to give these diagnoses with care and with compassion and honesty, and being in a very caring environment with your patient, listening to the patient, watching their responses to things, right? Understanding that the words that a doctor says in those moments matter tremendously. How do I describe this situation? And so, yeah, it can create a whole lot of unnecessary angst if that diagnosis is given poorly, or without the right intention behind it. So thanks for sharing that, Chris.
Thank you, Dr. McDaniels. We really appreciate your time, your expertise, and your research.
My pleasure. Happy to be here. Let me know if you guys need anything else from me.
Oh, we will. Thank you. We're grateful for you. Thank you, everyone, for attending today. And we'll see you another time soon.
Take care.
Bye-bye.